Welcome to the Jared Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex. Say is geared up. He's like, get me in there. Get me in there. I'm ready.
Go ahead, Say.
This is Saley.
And who else is in the room with us today?
So in addition to Say, we have Melissa Way, who is an assistant professor, physician researcher at the University of Michigan, general internist and researcher. She studies multimorbidity, and we're going to talk to her about a JAGS publication. Welcome to the Jerry Pal podcast, Melissa.
This is amazing. I can't believe I'm on. This is so exciting. Thank you for having me.
And this is one of our combined JAGS Jerry Pal podcasts.
Right.
And before we start every one of these podcasts, Melissa, we ask for a song request. Do you have a song request for Alex?
So I'd love to hear Bohemian Rhapsody.
Didn't you say we were just driving over and you said you put this song on repeat while you were shoveling the snow in Michigan?
Oh, I did. Yeah, it made the time pass by much quickly.
That's great. Mama just killed a man, put a gun against his head, pulled my trigger, now he's dead. Mama, life had just begun, but now I've gone and thrown it all away. Mama, didn't mean to make you cry, but if I'm not back again by this time tomorrow, carry on. Carry on, nothing really matters, nothing really matters, anyone can see, nothing really matters, nothing really matters to me.
Alex, I got a question for you. When does the operatic section kick in?
I'm not prepared for that. But
We're going to do it at the end. We're going to do the operatic section.
I'm just a poor boy. Nobody loves me. He's just a poor boy.
Out of all the songs to pick, Melissa, why this one? Is there a reason?
I've been going through a Queen phase and watching Bohemian Rhapsody.
And
it's always one of my favorite karaoke songs. But this movie definitely helped to...
Wait, so you do sing karaoke?
Not well.
Okay.
I
you
love
got to
it
sing in the
enjoy
end
it.
then. Definitely got to sing.
Okay, I'll join you for the
end.
operatic versions. I guess the listeners, they can tune out by then if they choose to.
So the overall topic of today is multimorbidity, and that's your main research area of focus. But before we get into the sort of more researchy stuff, it'd be great because most of our listeners are clinicians, practicing geriatricians, palliative care clinicians, people working in gerontology. Like, why should they be interested in multimorbidity? And what is that? Because I know it's a researchy term. Is it a clinical thing? How are they encountering this in clinical practice?
that was 17 questions, Alex. I counted
it. And after you answer that, we'll sing the song and end the podcast.
How did you get interested in it?
Yeah, so I came across multimorbidity in my general medicine clinic. So I was at Grady Memorial Hospital taking care of patients as an intern, and I remember struggling with how to take care of patients with multiple chronic conditions in a very short office visit. So we had a mix of several chronic conditions, acute conditions, preventive care needs, social needs, and I usually ran late in my clinic. And so when I was trying to find out how we could better take care of individuals, I realized that there were so many guidelines and there weren't really things that could be specific to each individual that I was taking care of. So it really started from a clinical standpoint as an intern.
And do you have a particular patient in mind that sort of exemplifies these issues of multimorbidity?
So one of the most profound patients that I took care of was one of these patients. So she had many chronic conditions, some of the common ones like hypertension and diabetes. But the most acute complaint that she came in with was knee pain or osteoarthritis. And we would spend the most of our visits talking about her arthritis, but at the same time, I had to take care of her other conditions at the same time. And I just realized that even over the course of a short residency program, her number of conditions grew, her number of medications grew, the number of specialists involved grew, and her touches of care with the healthcare system, whether lab draws or imaging, all increased over time. And by the end of residency, she had over 10 conditions, and she had poor mental health, poor physical health. And this really impacted me from a research standpoint because I wanted to know what I could do to better take care of her in clinic.
Mm-hmm. So what is, going back to, I think, question number 5 from Alex, what is, how should I think about multimorbidity? I see admission notes all the time, multiple medical problems, MMP for short. Is that the same thing? How should I be thinking about this concept of multimorbidity?
Yeah, so there are a lot of overlapping constructs with multimorbidity. So complexity, multiple chronic conditions, disability, frailty, high cost, high need. And multimorbidity is one of these constructs that tries to capture the complexity of the patients, including their medical issues that are coexisting all at one time. So multiple chronic conditions is another way to think about it. And there isn't necessarily one disease in particular of interest. So as opposed to a specialist looking at just their cancer or just their heart disease, it's really the holistic view of an individual and all of the conditions that they are surviving with.
So clinicians probably are most familiar with the phrase multiple chronic conditions.
Right, that's the most common used term.
So I can also imagine that if I have mild eczema, hay fever, some allergies, maybe some mild GERD, versus if I have COPD, cirrhosis, heart failure. I'm guessing there's a level, it depends on the types, not just the count, right?
Exactly. So with multimorbidity, the goal is to try to move beyond just counting diseases and realizing that the severity of the diseases differ. So if you have an end-stage organ disease versus, I don't want to belittle any disease, but there's just a range in how diseases impact an individual. So the goal is to try to capture that and basically come up with a walking measure of burden of disease for individuals.
You're going to get an email from high blood pressure complaining about, I deserve more.
Yeah.
Well, the high blood pressure patients take medications that give them adverse effects, so they actually get some of that burden.
They're retracting the email.
So one question I had is, as both a clinician and now a national expert on multimorbidity, what have you learned from your research that you feel like other clinicians should actually do differently for patients who have multimorbidity?
I think a lot of things we do are reactive, and the goal is to try to be more proactive. So are there ways that we can, if we know an individual's prognosis in the long run, what are things that we can be doing earlier to try to slow down the progression or prevent the progression of diseases? I don't have the answer to that, but that's one area that I think we need a lot of attention.
What? There's no simple answers? That's why we're here.
Physical activity helps a lot of the diseases, but it doesn't solve everything.
But this is so common in what we see, particularly when this is the Jerry Pell podcast. We talk about older adults who are complex. They have multiple chronic conditions. Often they also have disability. They may have cognitive impairment. They may have one dominant condition, or they may have multiple conditions at the same time. And so your work is really trying to capture some of that complexity, and specifically that complexity around people who have multiple chronic conditions at the same time.
Right, that's the goal.
Great.
Right.
So let's talk a little bit about sort of maybe before we a little bit more before we get to the JAGS paper. I'll try to ask one question this time. You've created an index, so maybe you could tell a little bit to our listeners about what is this index you've created.
Okay, so when I was a fellow, I was looking for ways to measure multimorbidity, and I wanted to create something that was patient-centered, that used an outcome that mattered to individuals. And so I created an index called the Multimorbidity Weighted Index, where the severity of diseases are based on how they impact an individual's physical functioning or physical health-related quality of life. So a disease that has a lot of points, like multiple sclerosis, affects an individual's physical functioning pretty profoundly. And then other diseases that don't have as great an impact are weighted less.
And you developed this, do you want to just say briefly for our listeners sort of what kind of groups of people you developed it and have validated it in?
So it was developed in 3 large cohorts of community-dwelling adults, so roughly ages 29 to 90 plus. So there are the Nurses Health Study, Nurses Health Study 2, and the Health Professionals Follow-Up Study. So these are individuals who are great at self-reporting their health conditions, but they're not nationally representative. So it was important to validate it in a nationally representative sample. So I used the Health and Retirement Study to validate.
Right, which is a study of older adults. That is probably it's Mike Say and I use that all the time. It's our biggest sort of sandbox in terms of research, but community-dwelling older adults in particular.
Right, community-dwelling older adults, and they could have gone to the nursing home later, but they're still followed in the cohorts.
Mm-hmm. And is it just, do they have the disease, yes, no, or is there something about the severity of disease for them?
So it is a yes, no for a physician diagnosed chronic condition, and then the severity weighs in on how it impacts their physical functioning.
Mm-hmm. So they're weighted by how much they might impact physical functioning.
Right.
So like one disease might be weighted more than another.
Right.
Because it has a stronger impact on physical functioning.
That's correct.
One question that I'm kind of thinking about is I'm kind of struck by the incredibly broad age range of the folks in the model development cohort, and was wondering if you had looked at how the model performs, how your index performs on specifically older adults, because I'm biased and I'm a geriatrician, and also because it's the Jerry Pal podcast.
Yeah, so I looked at the median cut point. So I looked at above and below to see if there were differences based on age, and I didn't find a lot of differences, so I ended up using the entire cohort. One benefit was also to capture some diseases that were asked in the younger and middle-aged adults, but were not assessed in the older adults. And so part of it was combining and using all the data possible, but it is definitely possible to continue to stratify and look at specific age groups more carefully.
Great. And we should note that this index is now up on ePrognosis, which many of us are involved in.
Yeah, that was the highlight of the index.
So you can go to eprognosis.org. You can look at the calculators page, and you can find Melissa's. It's the Multimorbidity Weighted Index. Which also could be the Melissa Way Index, MWI, it's conveniently. But you've shown that this index predicts things other than physical function. Could you say a little bit more about that? Things other than what we're going to talk about here in the JAGS paper.
Right. So when I think about how multimorbidity impacts an individual, I have a conceptual framework that includes several outcomes ranging from physical functioning, cognitive functioning, health-related quality of life, disability, participation in activities, and the end-all outcome of mortality. So I've been looking at how the Multimorbidity Index predicts these outcomes over time and have produced a series of studies looking at these outcomes.
Mm-hmm. And you've studied mortality, you've studied...
Mortality, long-term physical functioning, some of the objective measures like grip strength, gait speed, cognitive measures like delayed memory, immediate memory recall, working memory, the TICS measure of global functioning.
Great. So those are things that you've shown in the past. Do you want to set the table now about this particular article and what question you were asking there?
So again, for those who are listening, we'll have a link to the JAGS article on our Jerry Pal website, and the title is Multimorbidity and Mental Health-Related Quality of Life and the Risk of Complicated Suicide.
So in this paper, I was interested in looking at the impact of multimorbidity and health-related quality of life. So it's obviously a universally valued outcome for individuals, but it's not often studied. I had the benefit of using the SF-36, which has several scales of both physical functioning and physical health-related quality of life and other mental health-related quality of life measures. But perhaps one of the worst outcomes of poor mental health-related quality of life is suicide mortality. And we currently don't have anything effective in our healthcare system to screen for individuals beyond just asking whether someone has an intent or plan to harm themselves. And so this index really looks at how the number of diseases and the severity of the diseases over time have an impact on them. And basically with more and more multimorbidity, there's an increased risk of suicide mortality.
Mm-hmm. And what population did you use in this study?
So this study is looking at the Nurses Health Study and the Health Professionals Follow-Up Study and the Nurses Health Study too. So these are health professionals, non-physicians.
Mm-hmm. And they tend to be older at this point in this study.
So it covered a range. I had older adults, but also younger and middle-aged adults. So basically, young women who shouldn't be dying at all had high rates of suicide mortality if they had high multimorbidity.
It is really interesting that your index developed to predict physical function predicts suicide. So I'm just trying to think, like, conceptually, how are those linked? Like, is there a story there?
Yeah, I think that there's physical health and mental health are intricately linked. And so when an individual has a lot of burden physically, their mental health is often also affected by it. And so in this study, we found that both mental health and physical health declined with worse multimorbidity.
And is this something that you think is ready for, you were suggesting that maybe this could be used for screening for suicidality?
I think that they probably need to validate it first before going real time, but I think it could be used potentially. I'd have to test it first to see how it performs.
Right. That sort of gets at sort of what's the next step for this, this index. You've shown that it predicts a number of outcomes, but how do you see clinicians using it? Like for our, geriatrics clinicians, our geriatricians, our palliative care docs, nurse practitioners, nurses.
Yeah, so the goal in building this index is to be able to use it and operationalize it in the clinical setting. And so the goal is really to have some real-time calculation where I can look at the medical record and say, like, how sick is this person based on their multimorbidity? So I'd like to eventually get this into the electronic medical record where it's automatically calculated based on chronic conditions. And we have kind of a walking burden of disease or physical functioning burden of this individual based on a number.
Have you done any sort of diagnostic test characteristics like positive predictive value or sensitivity specificity? And specifically what I'm thinking about is even if the hazard ratios are really impressive, if suicide itself is actually not very common, it may be this tool may actually identify many hundreds of people for the small numbers who are actually attempting or thinking about suicide. So I was wondering if we're thinking about that next step of how do we implement this, those sorts of questions, it seems like would be really important.
Yeah, so those would be the next steps before implementing it.
Okay.
Right.
Do you get a sense from this paper and what you've found already? Do you get a sense of like those in that highest quartile or decile, like how much more at risk are they compared to those in the lower? Does it do you get a sense of how good of a job it does to discriminate those two groups?
I think it does a fairly good job in terms of predicting mortality. So we have over 3-fold increased risk of mortality or over 6-fold depending on the population that you're looking at. And so I think there is good face validity with that.
Mm-hmm. And getting away from clinical applications, could you say a little bit about how some of our listeners are researchers. I have had some researchers come up to us at conferences and talked about listening to our podcast. So for those researchers out there, is there a message you want to convey to them about how they might use this index, the MWI, in their work?
I think a lot of times we try to risk adjust for individuals. So basically remove the potential confounding effects of all of their comorbidities. And this has traditionally been done in indices that weight diseases based on mortality. But I would argue that there are a lot of diseases that people have that are not directly linked to their mortality, but that have profound effects on their health-related quality of life. So for individuals who are interested in those outcomes, this would be one potential way to adjust for those other conditions.
Mm-hmm. And health systems too, right? In terms of if they're thinking about, who are the sickest patients, where do I direct resources? And maybe potentially for demonstrating to payers that they're taking care of sicker patients than other health systems, for example.
Yeah, so another way to potentially identify high cost, high need patients, complex patients.
Mm-hmm.
I mean, this seems right up both kind of geriatrics and palliative care when we're thinking about case finding and trying to find populations of folks that we can help with the most given the limited supply of palliative care. It seems like kind of right up that alley.
Yeah, I think of identifying individuals earlier based on their biologic age and not necessarily their chronologic age. So even in internal medicine, we have younger and middle-aged adults who could be geriatric based on their conditions, but if we move beyond age and look at the conditions that they have, it can make a lot more headway there.
And then we have an author of another prognostic index in the room, Say Lee, in the Lee Index. Do you want to maybe, I don't know who wants to take it first, but talk about the differences in those two indexes, because many people go to e-prognosis and use the Lee Index or the Lee-Schoenberg Index. Where does the MWI fit in, and how does it distinguish itself from those?
So I'll jump in. I think mortality indexes, I think, were the ones done first for a couple of reasons. Number one, the death is easier to measure than some of these other things. And I think what's really great to see from my perspective is how the field is continuing to move forward. I think we usually think of when the people who are at highest risk for dying are the ones who are at highest risk for needing nursing home care, highest risk for rehospitalization, highest cost. So a lot of these things are run together, and actually highest risk for functional decline. But the science is now to the point where actually if we develop a model specifically to measure functional decline, we can do better at that than trying to use a mortality index to also look at functional decline. And so I feel like what Melissa has done with focusing on function as the outcome, she was able to find things that actually have great face validity. And so we talked about how osteoarthritis is not something that actually puts you at higher risk of dying sooner, but it is incredibly important for putting you at higher risk of of having lower functional status. So I see kind of the work that Melissa is doing in terms of functional status as a natural evolution of some of the work that I did now a while back.
Well, thanks. That's really kind of you. I'm in a room of giants for the prognosis indices. So I do think of multimorbidity and how diseases impact an individual on a real continuum. So mortality is the ultimate outcome that you want to prevent. But the goal is also to look at what can we look at upstream to that. So declines in physical functioning, declines in health-related quality of life, declines in disability. What can we do to try to decrease the slope or the rate that these are happening?
So let's go back to, you started off talking about the challenges you faced as an intern and how this got you to think about multimorbidity. Has what you've done already changed how you care for patients on a day-to-day basis? Like, has it shifted how you think about it? And are there some practical things that we can give our listeners as far as things that we can apply to our practice? Now I just did what Alex did. I just asked like 4 questions. You can tell we are professionals at this.
Do not try this at home.
These are great questions. Yeah, so I do think that my work in multimorbidity has impacted how I examine patients, and I think about their long-term prognosis as well as the office visit right in front of me. I try to look at their more like patient goals-directed care, so some of what Mary Chinetti is doing and really trying to focus on those issues. I also think about screening, so some of like Louise Walter's work, and should this individual be screened based on their chronologic versus their biologic age. I also think about initiating advanced care directives earlier for someone who's functionally much older than their age would suggest. So there are a lot of possible areas. Also, if someone has osteoarthritis, I try to send them to PT. I try to find other ways to get people moving and more physically active.
Last question from me. What's next for you? What's the next thing in this research pathway?
So I think that multimorbidity could go in several different directions. So when I think of the conceptual framework, there's areas of preventing multimorbidity. In the center is measuring multimorbidity. And then the end result is better taking care of individuals with multimorbidity. I think it's a lifetime of work over time, but I'm currently focused on trying to see how this would perform in an electronic health record. So I'd be interested to see how healthcare systems could use such a tool. Great.
And Alex, what's next for us?
Next,
say operatic, say operatic, say operatic, say operatic.
We will try say the operatic, though I have never played the chords.
Melissa, I want to thank you very much for joining us.
Thank you so much.
Thank you guys so much for having me.
Joining us with a little
great to have you here.
Bohemian Rhapsody coming up. Okay, Alex, a little operatic section.
Too late, my time has come. Send shivers down my spine. Body's aching all the time. Goodbye, everybody. I've got to go. Gotta leave it all behind and face the truth. Mama, I don't wanna die. I wish sometimes I'd never been born at all. All right, here we go.
If you're listening, join in.
I see a little silhouette of Silverman. Scaramouche, will you do the fandango? Thunderbolt of lightning, very, very frightening. Galileo, Figaro, Magnifico. I'm just a poor boy, nobody loves me. He's just a poor boy from a poor family. Spare me life, but Mom Josephine. Oh, wait. Easy come, easy go. Will you let me go? Beelzebub, no, we won't let you go. Beelzebub, we won't let you go. Mamma mia, mamma mia, mamma mia, mamma mia. Beelzebub has a devil set aside for me, for me, for me.
I think we just lost all of our listeners.
Down to 0.
If you are still listening out there, thank you very much for joining us.
They're on to the next verse.
Well, yeah, we are. It is truly impressive that you stuck with that. We look forward to having you with us in our next podcast. Melissa, thank you very much.
Thanks, Melissa.
Thank you so much
Thanks,
for having me.
And goodbye, everyone. I just said Alex's intro line.
And goodbye, everyone.